Monitoring weight, as you already talked about with the cardiac system, tell your patient to weigh themselves every day, same time of day, same scale, same clothing. And just as a fun fact, 1 pound of weight gain equals approximately 500 milliliters of fluid gain. So I want you to record your weight every day. Write that down, write that down. I want you to let me know if you notice that every day or each day that you are increasing your weight, especially if you're a renal patient. Aldosterone is produced by the adrenal glands. ALD, adrenals, so maybe a way to get that. It regulates your blood pressure. Your renal system does a lot to regulate your blood pressure as well. That's where we just talked about that. This is important to know. Your renin is your hormone produced by your kidneys. It was what regulates your blood pressure. So you come in as a normal patient with normal renal system, kidney function, and you have a state of low blood pressure because you're in a state of some kind of whatever it is that you have. Your renin system kicks in, does the whole conversion process that's on this little picture, and it says, you know what, I need to get your blood pressure back up. It increases your blood pressure, gets you back to normal, which is great, which is what it's supposed to do. The problem when you have renal dysfunction is that the renin doesn't function correctly, and it keeps that patient always in a constant state of high blood pressure because of this whole renin mess up. For you, normal, that's good. The renin's doing what it's supposed to do. For this renal patient, it keeps them hypertensive. Creatinine clearance. For your patients, your inpatients, they will do an estimated creatinine clearance. Ideally, if we wanted to know how much creatinine your renal system is clearing, we would collect your urine for a certain period of time, and then we would know exactly how much creatinine your renal system is clearing, your kidneys are clearing. For our patients, we always want to do an estimate, and there's an equation that will give us an estimate. You don't need to know the equation. But on your chart, oftentimes, you will see an estimated creatinine clearance for all your patients, inpatients, because that will tell us how the renal system is working or not working. Should we give that patient nephrotoxic meds? Should we give them some pretty strong antibiotics, or their kidneys too stressed out that they can't handle it? So in red, or wine, whatever that color is, this is the most important approximation of renal function. That's why we run those numbers on our patients. So pay attention to that number, even if they're not in for a renal problem. We want to pay attention to that. You're sending them in for a contrast procedure. You're giving them medication. You're giving them chemo. Can their kidneys handle what you're presenting to the kidneys today? So that's an important number to keep track of. Which way will this go when you have renal problems? Down. Can't clear as much, correct. That's different than GFR, as we talked about. You also may see estimated GFR listed in your chart. That's calculated based on that equation. You don't need to know that equation. But that tells us overall, how is the colander or strainer doing? That includes everything. The last one included only just the creatinine, because that's the best indicator of kidney function. This one includes everything that's arriving at the colander. How well is it straining and filtering and doing all what it's supposed to do? And again, you don't have to memorize that equation unless you like to for fun when you're in your spare time, which I know you all have a lot of right now. Erythropoietin, that's a big deal. That's a hormone that gets produced by the kidneys as well. Poor kidney function, which way will this go? Down. Correct. It can't produce it adequately. How do you know that? You're going to have, this is what's responsible for your red blood cells. So, renal dysfunction, decreased erythropoietin production, decreased hemoglobin, and that's what you find that goes with your patients. So, highly likely that in a couple of weeks, your patient that presents with kidney issues, you'll be expected to know which way their labs will go. You have a patient that is in here, you're taking care of him, he's got chronic renal failure. Which lab findings do you expect to see? And if you answer that saying, I'm expecting to see a low hemoglobin, that tells me that you know that the kidneys produce erythropoietin. You know with kidney problems, it's going to be decreased production. Therefore, you know then the red blood cells will probably be decreased. Red blood cells will be decreased, so will the hemoglobin. We'll talk more about that when we get to hematology next week. Again, the kidneys normally excrete the wastes that need to be excreted to keep you in good balance. So your BUN will go which direction when you have a patient with kidney problems? Up. If you don't understand the whole increased serum numbers, decreased clearance numbers, we can talk about that one-on-one and I can explain it more. It's important to think, okay, it keeps getting produced in the serum, but when it arrives at the strainer, it doesn't get strained through, so it keeps getting produced in the serum. So the BUN will go up. Like I said earlier, don't type in BUN, or when you report off a number, we don't typically say, well, their BUN is 30. We just call it BUN. That's just the terminology that gets used. You're not expected to know this. We already covered neuro a couple weeks ago, but there are, depending on where the spinal cord injury is, will depend on how well they can do with either maintaining urine, voiding on their own, all those things. It just depends on what level things occur at as to what they can or cannot do from that standpoint. Older patients, as we said, everybody can't filter as well. They filter probably about half of what you filter. So therefore, we get really concerned when they're older age is one risk factor, and then we're expecting their kidneys to manage all kind of heavy duty meds. So always take that into consideration. If you're given a test question and we're giving you an age, that should factor into your processing and thinking through that. Why do they tell me that she's 50? Why do they tell me that she's 70? If you say that older people are anybody under the age of 65, you've lost 25 points on that test question. I'm just telling you. I know who you are and where to find you. Renal bruits, we don't typically auscultate for them. That's abnormal. If a bruit is noted, you don't need to know the slide. You do if you have a renal patient, you won't need to know it for the next couple weeks. Specific gravity, we already talked about that. That's a urine test. Serum creatinine in capital and bold and red. The only thing that causes you to have an elevated serum creatinine are renal problems. There's no other body system that's going to cause you to have an increased creatinine. So creatinine is a number to watch out for your patients, always. There's the normal. Which way will it go when you have renal problems? Up, correct? And the estimate is that you don't really have an elevated serum creatinine until about 50% of your kidney function is lost. So that's concerning when we see a serum creatinine of 2. Like, oh, yikes, there's some renal problems going on here. That's a number to keep track of always as a patient caregiver. That tells us a lot about that.